Good morning. Welcome to our scientific meeting of the cardiology from Hospital Israelita Albert Einstein. It's a great honor to start our international meetings today, the first meeting with the International Atherosclerosis Society, with no less than Peter Libby, who will present our speech. To have this such important speaker, and to our international audience, we have as chairman Dr. Raul Dias dos Santos and Dr. Elias Knobel, which I give the word now. Please, Dr. Elias.
Good morning, everybody. Let's start our international meeting and traditional meeting of the Department of Cardiology of Hospital Israelita Albert Einstein. Today is a special day because we will have an international authority, well known to all Brazilians, Professor Peter Libby, who will give a presentation on a subject of great interest in medicine, the changing landscape of atherosclerosis. At my side, I have also the pleasure to present Professor Raul Santos. He is a researcher of our academic research organization of Hospital Israelita Albert Einstein, and he is professor of São Paulo University. We are going to moderate this meeting. On behalf of the Cardiology Department of Hospital Israelita Albert Einstein, I would like to thank Dr. Libby for accepting this invitation that greatly honors us. Please, Professor Raul.
Well, good morning, good afternoon, everyone. I'm speaking now on behalf of the International Atherosclerosis Society, that I'm the president. And we're very happy and honored to participate in this joint session with Hospital Albert Einstein. And to me, it's important in two ways, right? First, because I work here, and second, because of that Peter Libby is our president-elect, and I have the honor to work with him already at IAS, and I'll be working with him on the next 3.5 years. In order to fill our duties and the commitment of IAS with the prevention of cardiovascular disease all over the world. So Peter is a good friend of Brazil. This is an international session, and I do hope we have colleagues from different parts of the world watching it. So unfortunately, Peter won't be able to speak Portuguese with us today. But anyway, so Peter, thanks very much for accepting the invitation of Einstein. And now you have the floor. Thank you, my friend. You're welcome.
Okay, that's looking better. Can you see me?
Yes.
Yes.
Okay, somehow the host had blocked my access to my camera. I'm now going to share my screen. And we'll get going.
Yeah, we see it, Peter. Go ahead, please.
Okay, fine. Well, thank you very much. We've resolved the initial technical difficulties. It's a great pleasure to be here and visit with friends locally in Brazil and internationally. I was asked to take a stab at summarizing an article which was published recently in Nature that was invited by Nature as a review on atherosclerosis. These are my competing interests. I do not accept any personal payment from pharmaceutical or device companies, but I do have a financial interest in a small biotech that does not market any products. And it's particularly nice that we've been able to pair with the Albert Einstein Hospital for this joint event with the International Atherosclerosis Society. So the main point that I tried to make in my Nature review was that human atherosclerosis is a moving target. And in this paper, I talked about what we thought we knew, what we think we know now, and what we have to learn. There's been a lot of change in our view of atherosclerosis, and please don't read this slide because I'm going to take it step by step. That's going to be what we'll do for the next 40 minutes or so. For example, in the past, we viewed atherosclerosis as primarily a lipid storage disease, but now we understand that it is actually inflammation that links dyslipidemia and other traditional risk factors to atherogenesis. I was asked to write a review on atherosclerosis by Nature almost 20 years ago, and I'm not going to insist on the inflammation angle for a couple of reasons. One, because this paper, published almost 20 years ago, seemed forward-looking at the time, but now we have not only talked about eventually furnishing new therapeutic targets, but we've actually done it. And I've spoken about that before many times, and certainly our Brazilian colleagues have contributed to some of the studies that have actually shown, beyond a doubt, that inflammation operates in human atherosclerosis, a contention that was actually quite hypothetical when I wrote this paper almost 20 years ago. Another reason that I'm going to not insist on inflammation is because I'm going to share the latest chapter in our clinical translation of inflammation in atherosclerosis in the context of the SOCESP meeting, where on the 11th I'm going to give a talk similar to this one, but on the 12th, next week, I'm going to be speaking about inhibição de intrusinases como zitivequimab in pacientes com alto risco aterosclerótico. That is, for the international audience, inhibition of interleukin-6 with a monoclonal antibody called ziltivekimab in high-risk atherosclerotic patients. So that's about what I'm going to say about inflammation, at least in the beginning of this talk. Now, another misconception about atherosclerosis is that it affects predominantly developed countries. And that's totally contrary to the current situation. And actually, the greatest burden of atherosclerotic risk is not in the market economies, but in the developing world. Now, I'm going to give you a sneak preview. I am the editor-in-chief of the 12th edition, the coming 12th edition of the Bromwald Heart Disease textbook. And I'm going to take a couple of the figures from this chapter on global burden of cardiovascular disease, which has been updated by these excellent authors, to make the point that cardiovascular disease is falling in high-income countries, but rising in those with low or middle income. I'll focus first here in the upper row at the blue wedge, which is cardiovascular mortality, which went in 1990 from about a fifth to almost a third by 2017, the latest data that we have available. But the opposite pattern prevails if we go to high-income countries, where it was over 40% of the deaths were due to cardiovascular disease in 1990, but it shrank to less than a third in 1917. Now, most Yankees view everything south of the border as one big mass. And of course, we know that's not true. And I'd like to show you some very recent data that makes the point that LATAM is not a monolith. Latin American countries are not all the same. If we look at the rates of cardiovascular death due to coronary artery disease in Argentina, you see men dropping quite a bit. The scale is truncated here. Women are dropping as well, and there's a total decrease in cardiovascular mortality in Argentina. If we move to Colombia, we see it's pretty flat. But if we go to Mexico, we see something very worrisome, and that is that in Mexico, the cardiovascular death rates are actually increasing, and this has been attributed to an increase in obesity and metabolic syndrome with the attendant cardiovascular risk in Mexico. Well, the demographics of atherosclerotic disease are changing. You know, we used to think of coronary thrombosis as affecting primarily middle-aged males, Caucasian males. And that just doesn't fit what we're seeing today in our acute coronary syndrome patient. We're seeing women, younger individuals, and the very old, and they're suffering increasingly from acute coronary syndromes. And you know, all of you know this from your practices, but because the change is so gradual, we don't realize what a complete shift there has been in the characteristics of our patients. So the risk profile and demographics of ACS, acute coronary syndrome patients, has shifted worldwide. In the past, we viewed this as primarily a disease of men, not the case anymore. We thought of it as striking white males, not the case. Older people, but now we're seeing younger people, and of course, now the very old. We saw people with high LDL, and now what we're seeing more in our coronary care units is people with well-controlled LDL, but dyslipidemia due to high triglycerides and low HDL. In the past, we had less obesity and less insulin resistance and diabetes, and of course, as you're aware, and is really poignantly exemplified by the situation in Mexico, we have growing obesity. And I'm going to spare you the usual colored maps that show the worldwide spread of obesity and diabetes. And in the past, 1950s and 1960s, we had prevalent hypertension and we had very few good tools for treating it. Now we have inexpensive and very effective treatments for blood pressure. So this is the Frank Netter picture of the typical 1960s acute coronary syndrome or coronary artery disease patient. Male, middle-aged, high cholesterol, hypertensive, a smoker, and of higher socioeconomic status. And you're all aware that that has changed quite a bit. The face of the acute coronary syndrome patient has changed. Let's look at some actual data. This is from an important compilation, now a little bit old, but still making the point that these trends, which have only been accentuated, underlie strong data. We see a drop in the proportion of Caucasians and an increase in the US in African Americans from the first reporting period to the second reporting period captured. We see more comorbidities such as diabetes, hypertension in the people, not the general population, but in the people who end up in the coronary care unit. And we see chronic obstructive lung disease as well, increasing with time. Diabetes, and now if you look at patients who are undergoing percutaneous intervention in the US, it's almost 40%. And here is a very troubling statistic that only less than a fifth of our US patients have normal weight when they present for PCI. This is a very, very worrisome trend indeed. Now, although the overall proportion of women is not changing that much in many situations, you can see in this French cohort, this registry of the entire country of France, that if you stratify women with ACS by age, that we see many more women less than 60 years old are ending up with acute coronary syndromes. And in the US, we see that fully over a third of patients with ACS are female. So this is by no means a male disease these days. And the clinical presentation is changing as well, isn't it? Again, this is something that we all know from our daily practice, but the shift has been so insidious, so gradual, that we may not really take it into account. We're seeing more non-SG segment elevation myocardial infarctions and fewer STEMIs. And we're seeing more myocardial infarction and less unstable angina. As a matter of fact, the highly sensitive late generation troponin assays have really made the diagnosis of unstable angina extinct. Well, here's one data set. There are many. This is from the Kaiser experience in California. And you see total MIs are going down a little bit over time, but somewhere around 2002, there's a shift, and non-STEMIs begin to grow as STEMIs are decreasing. And this is not just due to reclassification of unstable angina to non-STEMI, because we didn't have those highly sensitive assays in the early part of the 21st century. Now, we also have changes in our thinking about the pathophysiology of the acute coronary syndromes. In the past, we focused almost exclusively on thin-capped fibroatheromata and called them the vulnerable plaque, or some called them the widowmaker. But indeed, I'm going to show you that the vulnerable plaque is a misnomer and another mechanism of acute coronary thrombosis called superficial erosion, I would argue, may be on the rise as a cause of arterial thrombosis. So here is the famous plaque rupture, where you have the lipid pool with its coagulation components, procoagulant components, gains access to the blood through a fracture of the plaque's protective fibrous cap that overlies the lipid pool. And we spent several decades in my laboratory working out some of the cellular and molecular mechanisms of the thinning of the fibrous cap that is made of interstitial collagen that lends strength to this structure that is all that stands between many patients and an acute coronary syndrome. And I'm not going to bore you with all of the details of the cell and molecular biology and biochemistry. Suffice it to say that when we have inflammation in the intima, as depicted here by the macrophage foam cells and the blue T lymphocytes, they send signals to the other cells in the plaque. For example, the smooth muscle cell, which manufactures the collagen that lends strength to the plaque, to halt collagen synthesis, which is required to repair and maintain this all-important extracellular matrix. We also worked out the pathways by which the T cells could send signals to the more numerous macrophages and increase the activity of a series of enzymes that are specialized in breaking down interstitial collagen, members of the matrix metalloproteinase, or MMP family. But, you know, we tend to face today's battle prepared to fight the last war. And while we understand in considerable detail the pathophysiology of the so-called vulnerable plaque, let me play out with you the conjecture that the vulnerable plaque is not a valid concept in the current era. Where do we get this whole construct of the so-called vulnerable plaque? Well, it was from autopsy studies. And what's the entry criterion, sine qua non, for enrolling in an autopsy study? You have to have died. So while a pathologist can tell us from post-mortem what the morphology of the plaque was that caused a fatal myocardial infarction, We don't have the denominator from pathology studies. We don't know how many people are walking the streets with thin-capped fibroatheromata who do not have an acute coronary syndrome. And it turns out, using contemporary imaging methodologies, that few thin-capped plaques actually rupture. Perhaps the most prominent of the studies that made this point is Greg Stone's PROSPECT study that used the radiofrequency backscatter from the intravascular ultrasound to do a crude tissue characterization, which the practitioners agree can define what we call thin-capped fibroatheroma, pronounced TICFA. And in the PROSPECT study, they followed people who had TICFA up for a period of 3.4 years and found that less than 5% of them had a coronary event. So that means that 95% of these so-called vulnerable plaques were not vulnerable at all. They were quite stable from a clinical perspective. Why is that? Why are we seeing this shift in the clinical manifestations and presentations of acute coronary syndromes? For one thing, it's because statin treatment and other preventive measures, such as decreased smoking, better treatment of hypertension, and perhaps control of diabetes, have begun to modify atherosclerotic disease. There's secular trends in cholesterol levels worldwide. These are data from the US. Let me have you just focus here on the upper right-hand panel, which shows in Black men, Black women, white men, white women, in a multi-ethnic population in the US, that there is a secular trend towards a gradual decrease in LDL. Again, note the truncated y-axis here. Not only in the US, but also in Norway, there's a secular trend towards a decrease in cholesterol in the young and in the older. And of course, statin use has become prevalent. Since the landmark 4S trial in 1994, we see generic statins becoming much more widely used. In this particular study from the US, you have an unbelievable quarter of the US population is on a statin. These are just people walking down Main Street, USA. And if you look at patients with coronary heart disease, about 60% or over 60% are on a statin, and almost a third are on a high-intensity statin. So this is really, I believe, changing the disease. If we look in databases of performance measures, we see that even the most laggard hospitals in the US are now at least sending the patients home with a prescription for a statin after an ACS. Now, of course, we have to do a much better job of persistence and trying to get the patients to comply with the treatment and refill their prescriptions and take the medicine. And that's a work in progress and a big challenge to us from a behavioral perspective. But at least we're trying to do the right thing, even in the lowest 10th centile of US hospitals. Now, because of this, Gerard Passakamp from Netherlands and I wrote this provocative, deliberately provocative piece 5 or 6 years ago in the European Journal, The Requiem for the Vulnerable Plaque. We believe that the clinical presentation changing may reflect a change in the substrate, because lipid lowering can stabilize plaques. What do I mean by stabilization? Actually, we hypothesized this all in the mid-1990s on the basis of our laboratory work, that if you have a large lipid core and a thin fibrous cap, and you subject that individual to profound lipid lowering, that you can reinforce the fibrous cap, reduce the lipid core, and very importantly, from my perspective, decrease inflammation. Now, we did many studies in the laboratory, and many other laboratories did as well. I summarized these a number of years ago, showing all the things that went in the right direction in rabbits and in mice when we lowered cholesterol, either with diet or with statins. But the collaboration with Gerard Pasterkamp and Hester den Riete was particularly valuable because their Athero-Express tissue collection allowed interrogation of human plaques over different time periods and made the very clear observation that inflammation is decreasing with time in human atherosclerotic plaques, and the lipid core is shrinking by over 50% in Netherlands, which is a country with very state-of-the-art lipid-lowering therapy penetrates. So human atherosclerosis is changing before our very eyes, and I believe that that is an underlying mechanism for the changes in the clinical presentation. Now, of course, to be in the AtheroExpress biobank, you need to be able to have qualify for a carotid endarterectomy or other biopsy of the plaque. Most are carotid endarterectomies. But if you look using imaging technologies, either intravascular ultrasound or magnetic resonance imaging, you see that people who don't have to show up to the operating room for treatment have the same kind of changes in their plaque with intensive statin treatment. Not much change in the lumen, we knew that from the older angiographic studies, but a big decrease in lipid core, a relative increase in the amount of fibrous tissue, and curiously, an increase in calcified tissue with intense statin treatment. So think about that before you order serial calcium scans, coronary calcium scans on patients who are on statins. So if vulnerable plaques are less prevalent and cause fewer acute coronary syndromes, what mechanisms do account for this residual burden of events? The coronary care units are by no means empty these days. Well, that's, as I hinted earlier, due to a different mechanism, superficial erosion, made famous by Renu Vermani, where we don't have a thin capped fibroatheroma, we don't have a fracture of the fibrous cap, but endothelial erosion. I'm not going to go through in this talk all of the details of either the pathology or the pathophysiology of erosion. Suffice it to say that it's very, very different from the thin capped fibroatheroma, the so-called vulnerable plaque. Some of the characteristics which are almost hand in glove from the vulnerable plaque, so-called vulnerable plaque, are shown here, and you can read about it in several reviews that we published. Using optical coherence tomography, which is an experimental technique or a research technique, is sometimes used appropriately in practice, you can really see plaque rupture by the discontinuity in the fibrous cap, and this is the ulcer cavity where the lipid core used to reside, probably. This is in cross-section. This is a long axis view of the plaque. And erosion looks very different. Non-rupture, no rupture, and you often have a sessile thrombus with the characteristics of a white thrombus instead of a red fibrin-rich erythrocyte-trapped kind of thrombus. This is a citation that you can go to if you'd like to learn more, where we teamed up with Filippo Crea and I.K. Zhang to really bring you up to the state of the art using optical coherence tomography definitions. And what you find in a contemporary series is that superficial erosion is not just a fifth of plaques that cause an acute coronary syndrome, but actually looks like it's the culprit in about a third of acute coronary syndromes. So I believe that superficial erosion may be on the rise as we get better control of the engine that drives the formation of the thin cap fibroatheroma. And it fits with the decline in STEMI and the rise, relative rise in non-STEMI. These are data, again, from the world OCT literature that were gleaned by Raul and Hester. And it shows that in STEMI, 70% plus are associated with an OCT plaque rupture, where it's the opposite pattern in non-STEMI. A majority of non-STEMI are associated with no plaque rupture or presumably erosion. Now, I'm not going to go through all of the pathophysiology, which is a major portion of my own laboratory effort these days. But we understand a lot about the mechanisms of plaque rupture, and I spent, as I said, several decades working that out. But we know almost nothing about the fundamental cellular and molecular mechanisms of plaque erosion. Way back in 2000, over 20 years ago, using very primitive graphics from the original Mac Paint program, I drew this picture where we hypothesized that endothelial desquamation due to lysis of the extracellular matrix and endothelial cell death due to apoptosis or other mechanisms could contribute to superficial erosion. And more recently, we've been able to actually provide evidence that some of these conjectures from way back 20 years ago are true. I just want to project this one title of one of our early studies, the in vitro studies, because in addition to my French fellows, we had a Brazilian medical student from FIN-USP, Aniel Araújo, who spent a year with us and who contributed to this study. And I'm not going to go through the details here. Suffice it to say that we have put together a pathophysiologic scheme and some evidence to support these various steps for the pathophysiology of superficial erosion, which is very distinct from the pathophysiology of the acute coronary syndromes due to rupture. And we have in particular implicated neutrophil extracellular traps, or nets, in the kind of thrombus that we get with superficial erosion. Again, I'm not going to go through all of the details or the alphabet soup of what we do in the basic science laboratory. Suffice it to say that we have very strong evidence in mice for the operation of net formation, which is on the cutting edge of thrombosis research these days as an underlying contributor to thrombosis in superficial erosion. And here in a human LAD, left anterior descending coronary artery, we see the markers of neutrophil extracellular traps, the citrullonated histones. The full version of this story I'll tell another time. And actually I did a few years ago at SOCESP. Now, why is this clinically important? Why does it matter if we have a plaque rupture versus erosion? It's because they may need different treatments. It may be that the platelet-rich, non-completely obstructive thrombus that we see most often with OCT in superficial erosion doesn't require an immediate trip to the interventional laboratory for stenting. But the patients could be managed with intensive antiplatelet therapy. And my collaborator and friend, I.K. Zhang, actually did a study, a preliminary study, pilot study, that showed that this may be feasible. And we need to do a much larger study, but I think that's the direction that we have to go. So Filippo Crea and I got together a few years ago and thought about this. Here we are, well into the 21st century, and how do we triage our acute myocardial infarctions in your emergency ward and in my emergency ward today? Well, it's on the basis of a technology which was developed in the early 20th century, was recognized with the Nobel Prize to Eindhoven almost a century ago. So we're using the scalar electrocardiogram, ST segments up or not, to triage our patients. And in the meantime, we've learned so much about the pathophysiology and mechanisms of acute coronary syndromes. Can't we do better? So Filippo and I issue a call for a more mechanistic approach to the categorization of acute coronary syndromes to provide a framework for future tailoring, triage, and therapy for patients in a more personalized and precise manner. Now, we aren't there yet, but one of the reasons that my laboratory is focusing on erosion is to try to work out biomarkers that may allow us, perhaps in point of care, to triage people who need to go to the cath lab immediately and those in whom we can temporize and try antiplatelet therapy. Well, I'm going to sort of begin to wrap up with another contrarian view, is that in the past, many of us, including myself, were convinced on the basis of observational epidemiology that high-density lipoprotein, HDL, was protective against atherosclerosis. And I'm going to play out with you in the next chapter of this talk the possibility that we got this very, very wrong. And that in fact, it is triglyceride-rich lipoproteins that are causal in atherosclerosis. That is a complete change in mindset for many practitioners. Why did we believe so firmly that HDL was protective? Because in a population, in study after study, in country after country, there is a very strong inverse relationship between HDL cholesterol and cardiovascular risk. However, we must bear in mind that we can be very, very misled by biomarkers. Think about suppression of ventricular ectopic activity and the CAST trial. Think about all the positive inotropes in heart failure that turned out to increase mortality, although the ejection fraction was improved acutely. So just because a biomarker associates with an outcome does not mean that it's protective or causal. Okay. Human genetics now offers a new window on causality. This is one analysis that was a very strong analysis that was presented by Sekar Kathariasan and his colleagues at our sister institution, the Massachusetts General Hospital, where the outcomes were compared with observational epidemiology versus a genetic score, which would change the factor. So let's look here at what the observational epidemiology is telling us. That if you have a one standard deviation increase in LDL cholesterol, that you have an over 50% increase in coronary heart disease. And if you have a 1 standard deviation increase in your HDL, it looks like you have an almost 40% decrease in events. This is the observational epi. But now let's look at human genetics, where we look at lifelong exposure, area under the curve, to either high LDL or high HDL based on variants that you inherit from mom or dad. And in the case of LDL, well, you have an over 2-fold increase in risk if you've had a 1 standard deviation increase lifelong in LDL. And why is this higher than the observational epi? Because this is from birth, and this is just looking at a point in time in ecological studies. But if you do the same exercise with people who had lifelong genetically determined increase or higher level of HDL, non-significant. And this is just one of a number of human genetic studies that have cast doubt on the protective role of HDL. And then we have the consistent failure of clinical trials aiming to raise HDL. The fibrates, nicotinic acid, CHP inhibitors have all failed, as have several ways of raising ApoA1. Meanwhile, we have to think about triglycerides. Why? Because triglycerides and HDL vary inversely. So on a population basis, those with low HDL will have high triglycerides. And we've traditionally ignored the triglycerides and focused on the HDL. Remember that triglycerides are just a biomarker for a class of, or classes of triglyceride-rich lipoproteins. Some call them TRLs, I call them TGRLs, or remnant particles belong to this family. So where do we stand? Pharmacologic attempts to raise HDL have consistently failed to reduce cardiovascular events. Human genetics do not support HDL as a protective cardiovascular factor, but in contrast, the contemporary human genetics strongly support a role for triglyceride-rich lipoproteins as a causal risk factor. Now, why did we lose our way, including me, where we really were so convinced by the observational epidemiology? It's because we adjusted triglycerides for HDL. So here we have unadjusted data, or data that are just adjusted for age and sex, looking at triglyceride concentration versus hazard ratio for cardiovascular disease. very nice linear relationship. If we further adjust for non-lipid risk factors, it attenuates the risk. But then if we adjust for HDL, what happens? It's flat, okay? But let's think about this for a minute. You know, this is an example of how to lie with statistics, because non-HDL cholesterol captures the triglyceride-rich lipoproteins, that part of the ApoB compartment. And adjusting a risk factor for itself obviously is going to attenuate the risk estimate. So we went around adjusting the triglycerides for HDL. We were so convinced that it was protective that we may have lost our way. So I again wrote another provocative piece, triglycerides on the rise, should we swap seats on the seesaw? And by that I meant, did we bet on the wrong side of this dyad? Because HDL and triglycerides tend to vary inversely. Okay? Did we confuse the dependent and the independent variable when we adjusted the cardiovascular risk of triglycerides for HDL? And recent genetic studies have one by one snowballed to support the causality of triglyceride-rich lipoproteins and cardiovascular risk. This is the world in which Raul and I live, and the alphabet soup of lipid metabolism. I will spare you the details. I will not go into what angiopoietin-like 3 and angiopoietin-like 4 are, but suffice it to say that we know that these are elements that are genetically encoded that can regulate triglyceride-rich lipoprotein levels and that very, very tightly associate with disease, and using Mendelian randomization, contemporary genetic techniques have been shown to be causal. And what they have in common is regulating an enzyme that you have probably forgotten about from medical school called lipoprotein lipase, which is attached to the surface non-covalently of the endothelial cell and which functions to take triglyceride-rich lipoproteins and trim the triglycerides, giving us smaller particles and free fatty acids. And these various, this alphabet soup of genetically determined factors that alter triglyceride-rich lipoproteins and events actually have a common principle, is that they regulate the activity of lipoprotein lipase. The ones that I have depicted here as devils inhibit lipoprotein lipase, and that will just cause accumulation of these triglyceride-rich lipoproteins because LPL can't do its job. And there's one apolipoprotein that does the opposite. It's an activator of LPL, and the genetics show that it's protective, as do the experimental work. And what about the link between inflammation, which I started with, saying that inflammation can link traditional risk factors to altered behavior of cells in the artery wall? Well, it turns out that the TGRL are much more pro-inflammatory than LDL. And the greatest proponent of that has been Borge Nordestgaard and his group, very powerful group in Copenhagen with wonderful cohorts and great analyses, showing here, if we look at inflammation gauged by C-reactive protein in the blood, we see that as triglycerides go up, the C-reactive protein goes up in the red line. And if we do the same exercise with LDL, it's flat. So TGRL are pro-inflammatory, much more so than LDL. And the mechanisms by which TGRL can incite inflammation are understood at some level and speculative at another, an emerging area. But if you'd like to read about it, I refer you to this recent paper that we published in ATVB. So my bottom line, my take-home message is that we have to keep our eye on a moving target. The face of acute coronary syndromes and of atherosclerosis are changing. Human atherosclerosis is a moving target. So the challenge to us is to orient our thinking to address today and tomorrow's disease, not the problems of yesteryear. And we should keep pushing to learn more and to be able to bring it to advances in therapy for our patients. Now, one of the dichotomies that I put forth in this Nature article I'm not going to talk about today. That is that we used to think of atherosclerosis as an inevitable, steadily degenerative accompaniment of aging. And I'd like to leave you with the thought and refer you to the discussion in the Nature article for evidence that actually we can take a much more optimistic view today. Atherosclerosis does not evolve in a monotonically progressive way. There are crises in the history of an atherosclerotic plaque. Plaques can regress. There can be subclinical disruption and healing, and lifestyle and medical measures that we have in our armamentarium. And those that are on the threshold can modulate this process. So I'd like to leave you with the thought that all of this ferment in thinking about atherosclerosis really means that we can get better control of this disease and prevent events and give our patients longer and healthier lives. So I'd like to stop there and leave plenty of time for discussion. And these are some of the people in my lab and close collaborators that have contributed to some of the basic science work that we've done. And of course, I have strong clinical collaborators as well who've helped with the translational aspects. Back before we had COVID, we could get together in my backyard. And this is a laboratory group from a few years ago, pre-pandemic, with people who have been able to contribute to this work. Thank you very, very much indeed.
Thank you, Professor Libby. I would like to congratulate with your excellent presentation that will change our views on atherosclerosis. Now we have questions from the audience, and I would like to make one question that previously was made. One of our fellows here would like to ask you, how do you believe the preventive treatment for atherosclerosis will be? He wrote, in the next 20 years, I will change in the next 5 years from now.
Well, the first thing is that LDL is solved in principle. And when we have the newer tools, such as bempedoic acid, which is approved in many jurisdictions, which can be added to statins or be used for statin-intolerant patients in combination with ezetimibe, gives us a new tool to manage LDL. And then very exciting on the threshold is inclisiran, which is the RNA, the siRNA, which we've learned a lot about siRNA in the last months, haven't we, with the power of the vaccines. But the siRNA gives us a way to lower LDL with 1 shot a year or 2 shots a year in secondary prevention. So a lot of the problems that we've had in having our patients take a pill every day or take an injection every 2 weeks or a month is going to be eradicated by the availability of the siRNA. In combination with statins, we're going to be able to drop the LDL into the sub-basement. So that's a couple of tools for LDL. And then there's Lp(a), which is a causal lipoprotein for which there are 2 RNA therapeutics that are being developed. One's already in an outcome trial, and the other will enter soon. And we're going to finally have a tool to treat the individuals with very high cardiovascular risk, atherothrombotic risk due to elevated Lp(a). Then in terms of anti-inflammatories, we know about the studies with colchicine. We're going to hear from Dr. Protasio during Sofesti about the use of colchicine in COVID in the CoCorona study that he helped to coordinate in Brazil. So we'll have, I think in the next 5 years, we will have anti-inflammatories that we will use in selected patients. How we're going to target them with biomarkers is going to be a very interesting development. And I see in the crystal ball for the future that we're going to be using genetic markers to segment our population, to look at those in whom the risk-benefit ratio comes out on the most favorable side for different types of therapy, be it LDL lowering or Lp(a) lowering or anti-inflammatory treatments. And then targeting those triglyceride-rich lipoproteins, we have the omega-3 fatty acid, icosapentaethyl, which part of its success in reducing cardiovascular events may be due to triglyceride lowering. And then we're involved with a large-scale outcome trial with a novel selective PPAR alpha modulating agent that is related, but not exactly the same thing as a fibrate, called pemafibrate, which is very potent and very selective and very well tolerated so far. And that is in clinical trials and may give us a tool that can vastly lower triglyceride-rich lipoproteins and some of the fellow travelers like apolipoprotein C3. We have a number of other lipid-directed therapies and the anti-inflammatory therapies. So I think in 5 years, our practice will be changed.
Dr. Peter, I have a question from the audience about the inhibitors of EL6. The question is, why is a new anti-EL6 is being tested for fight atherosclerosis, the Vicimab? I do not think the market needs more anti-EL6 products, in particular, since some kinase inhibitors are almost also anti-EL6 and are orals.
Right. So I'm not familiar with oral anti-IL-6 inhibitors. The anti-IL-6 receptor antibody tocilizumab has been studied in a few smaller scale clinical trials done actually in Norway. And the most recent of these, ASAIL-2, showed a modest benefit in magnetic resonance indices of ventricular function in patients with ST segment elevation myocardial infarction who were treated acutely with tocilizumab. The problem with tocilizumab, the IL-6 receptor antibodies, is that they tend to increase triglycerides. And that's actually been even seen in Brazilian populations. So for chronic treatment, because we think that triglyceride-rich lipoproteins are provoking atherosclerosis, we have avoided the anti-IL-6 receptor antibodies. Ziltivekimab is an inhibitor of the cytokine IL-6, not of the receptor, and it looks like it's cleaner from a cardiovascular risk perspective. The study, which I will speak about next week at SOCESP, and it was presented by Dr. Raker at the American College of Cardiology meeting a few days ago. The rescue trial was performed in patients who were really an unmet medical need group. If you think about the populations in which statins have failed, it's really only advanced heart failure and chronic kidney disease. And the population is targeted in the rescue trial, which was the phase 2 trial, which I'll speak about next week at SOCESP, was a chronic kidney disease population. And a trial is in the planning stages, late in the planning stages, to do an actual cardiovascular outcome trial with ziltivekimab, which is the anti-IL-6 antibody.
Okay, so Peter, this is Raul here. We're living epidemics of obesity, right? And as you've shown very clearly, there was a reduction in LDL, but now with obesity we have more triglycerides, rich lipoproteins, elevation, we have more inflammation. We all prescribe lifestyle changes, right? But we know how difficult it is to really make people lose weight and eat well and exercise. So we have evidence that maybe the GLP-1 agonists can change, especially, secondary prevention is clear, right? Primary prevention, we still need more data. But what do you think about, because, you know, people say, oh, you're all wanting to push medications in everyone, but we know that it's very difficult. You showed the example of Mexico. Mexico, you know, the number of young people with diabetes who have cardiovascular disease, who have kidney failure and die of that is huge, right? So do you see the possibility of using these GLP-1 agonists, especially now oral ones, maybe for long-term prevention of, because they will treat obesity, they will reduce inflammation, they will improve the lipids. So what do you think about that? I think it is definitely should be studied. We're so fortunate since 2015, we have two classes of glucose-lowering medications that actually reduce cardiovascular events, which has been the holy grail of diabetology, at least of cardiodiabetology. For decades. We had disappointment after disappointment looking at reduction of cardiovascular events with hypoglycemic drugs. So with the GLP-1 receptor agonists and the SGLT2 inhibitors, we have two new tools that actually have different profiles and probably apply to different patient subsets that can reduce cardiovascular events. It's very exciting. And we need to make them really available. We need to have the data to justify their use in primary prevention, and we need to then provide access to a broad population. So, healthcare disparities are an issue which have become even more exaggerated in the era of this pandemic that we've lived through. And I think it has heightened the sensitivity of each of us in our professional and ethical responsibility to labor to provide more equitable access to therapies to less privileged groups. And I think that the currently expensive SGLT2 inhibitors and GLP-1 receptor agonists are examples of drugs that may have great utility in selected patients, even in primary prevention, but that may be out of the reach of many members of our society, and we have a duty to try to remedy that.
Any other question?
Yes, we have another question from Paulo Ber. What about polygenic risk scores in detecting early coronary artery disease?
Yeah, I think it's a great idea. So I said, I view us, when I said I look in the crystal ball, we'll be using genetics to target therapies. We can't write prescriptions for statins for every 14-year-old. It's a complete societal failure to do that. But using polygenic risk scores, like I showed in that example from the juxtaposition of observational epidemiology and the polygenic score for controlling or regulating LDL or HDL, that the lifelong exposure to the putative protective factor or the causal risk factor makes a big difference. So since we're born with DNA that we're going to live with all of our life, I like to say that the sketch on the canvas is our genomic DNA, but the full portrait of cardiovascular risk gets painted by our behaviors and interventions. And so we're able to determine at birth really people who might have greater risk and who need to be particularly mindful of adhering to a healthy lifestyle. And I think we'll never have appropriate clinical trials because we don't have long enough follow-up. But we're going to have to make some judgments as a profession, as a society, about pharmacotherapy in younger people with high polygenic risk. So I think the polygenic risk scores are going to be part of our practice going forward. I agree.
Dr. Libby, we have almost 1 hour of discussion here in your presentation. And I would like to thank you so much in my name and the name of the Department of Cardiology of Hospital Israelita Albert Einstein. And we are looking forward in the near future to have you here visiting this hospital and our colleagues here that appreciate so much your presentation. Thank you so much again.
It's been my pleasure, my honor, and you can count on me to come visit when it's safe.
I would like to thank you so much for our first international meeting here at Albert Einstein with such a brilliant speech from you. Thank you so much, Dr. Peter Libby. See you forward in the next future.
Thank you. Bye-bye.
Bye.
Bye-bye, and thank you again.
Thank you.